Thank you for your introduction, and hello everyone. Today's my topic is how to increase stability of fixation in elderly patients. So I hope this lecture will be informative and beneficial for all of us. I will talk about the first one, the characteristic of poor bone quality and the basic principle of fixation of orthopotic bone. Finally, I will introduce the techniques for enhancing stability with augmentation. Aging changes bones. In cortical bone, the cortical thickness is decreased like this one. By compensation mechanism, the whole medullary diameter is increased to maintain bending stiffness. So it decreased thickness results in less working length of implant. So in the elderly patients, unicortical locking screw should be avoided. How about the cancerous bone? The aging also changes the cancerous bone as well as cortical bone. The trabecular thickness is thin and broken, and the number is decreased. So the result is reduced pore strength, like screw failure and secondary bone loss, reduction loss. So the poor bone quality may result in the more fractures and operative complications, including failure of fixation and secondary loss of reduction and spontaneous peri-implant fractures. So we need something special. So the angular stability is very nice to improve the clinical outcome in elderly patients. The locking plate is very nice. And the basic principle of fixation in orthopotic bone is the IM nailing always better than plate and screw. When you use the plate, a locking plate is better. And bone impaction implant is better than bone removal. We sometimes need bone augmentation. So in the surgical fixation, relative stability with IM nail or long plate is more commonly used. What else other than the basic principles? The solution can be found from the patients. You can see the three cases, very similar cases, 83 years female, 81, and a little younger than 68 years female. How about this one? The distal femur fracture with a spiral pattern. What will you do? The patient factors in bone quality should be considered, and then your preference and the primary goal of the elderly patient is only weight bearing with independency. So the first case is 83 years female, distal femur fracture. My young resident from the other hospital, he did the dual plating like this one. How about this one? I think it's a short plate. So 6 months later, the plate is broken and non-union has happened. So I have to revise it. I did like this one. I removed the lateral plate and antegrade nailing for prevention of the femur neck and intertrochanteric future fracture. And in distal fragment, there is a little short of the stability. I put augmentative plating like this one. And for non-union treatment, I put Autobone and BMP2. And after fracture, she couldn't walk. But immediately after the revision surgery, she started walking like this one. And 3 months later, you can see the bone union like this. And 5 months later, and you can see the bone bridging and consolidation. Let's move to second case, 81 years old female. Distal femur fracture. The wiring makes the reduction and retrograde nailing was done. How about that? Only tolerable weight bearing is permitted. It's very nice, looks very nice. A couple of months later, she acquired the bone union. However, 60 years later, she slipped down again. Her age is 87 years old, the female. The femur neck fracture has occurred. So I have to remove the retrograde nailing and then to the hemiarthroplasty like this one. This is another case of the 79 years old female. This is a non-union case with peripressive fracture. What is the problem list? Inappropriate reduction of distal femur, so much gap, and no evidence of fracture healing. Inappropriate plate length. The plate is short, and short working length. Working length means the distance between the most distal screw of the proximal part and the most proximal screw in the distal part. This working length is short, and too many crowded proximal screws and additional peri-implant fracture. I have to fix it, so I'll remove the lateral plate and anti-grid nailing to prevent the future neck and trochanteric fracture. And for the striking technique, I reduce the fracture gap, and to enhance the distal stability, so I put the lateral plate like this one, and she could start working immediately after the revision surgery. And finally, she got the bone union. How about this third case? 68 years old female, for distal spiral fracture. The fracture extended to the probably intra-articular region. I did plate on nail because I prefer this technique because it allows the tolerable weight bearing immediately after surgery. I mean, for distal part is the stability is not enough, so I did the augmentative plate like this one. Then in the intramedullary nail area, I put the attachment plate like this one. So 4 months later, she got the bone union, and the result is very happy. So adjunctive fixation, plate on nail construct initially emerged for the non-union treatment, but I recommend that this stable fixation allow early weight bearing. So in the distal femur fracture, I prefer the anterior nailing with this kind of adjunctive fixation. Let's move to other technique. Another lesson from the patient. 55 years female, male, periphrostic fracture. What will you do? The bone stock, distal part of bone stock is very poor. There is no space for fixation. So I opened, so the anatomical reduction and leg screws are fixed. And then with small plate, I do the protection, the neutralization plate like this one, and main stabilization with large LCP combined with attachment plate. So this is the post-op X-ray. The attachment plate is like this one. The 3.5 millimeter screw can be inserted eccentrically. So you can find a small area of the screw fixation. So 6 months later, he got the bone union. So I introduce my indication of dual plating of distal femur fractures. In distal femur, the periphrostic fracture or the far distal femur fracture or medial side comminution is very important. And or poor bone quality in elderly, I do the dual plating. I reported 9 years ago the safe zone of medial MIPO in dual plating of distal femur. The anteromedial is very safe, and far proximally, the anterior side is far from the femoral artery, so it is a very safe zone. You can remember this anteromedial is the safe zone for medial MIPO. This is my clinical outcomes. I did dual plating of distal femur. The result is excellent union rate and well-maintained alignment is acquired. Very nice. How about the proximal tibia, periprosthetic tibia fracture? This proximal tibia, there is no space to insert screw. So I did dual plating, 100% of bone union and well-maintained alignment. You can compare the dual plate and single plate like this one. In the first case, in single plating, there is no buttress of lateral side, so times go on, the collapsed and the valgus malalignment was happened. How about this dual plating? There is no space for not enough space for proximal part, but dual plating is maintaining holding the proximal fragment. The union is good bone union and well-maintained alignment. So the dual plating is the periphrostic tibia fracture is very useful. How about the periphrostic femur fracture after total arthroplasty? My surgical technique is a reduction plate with small plate and augmentation plate with long plate. I show the case. 90 years old female, thank you for type B1 fracture. The distal part is a spiral fracture involving the stem tip. I first opened and the anatomical reduction and the leg screws are fixed, and then I did applied the neutralization plate with small plate, and then main stabilization with a long, large plate like this one. And then 5 months later, she acquired the bone union like this one. It is a very useful technique. So you can use attachment plate like this one, this is a large plate. You can fix the attachment plate here, and you can insert the small screws like the racking and conical screws like eccentrically. This is a new version of the periphrostic fracture, and this is another plate from other company. You can use this one, and you can fix through this hole. You can fix the small screws to the greater trochanter. So this is for the periphrostic fracture. I'll level my message, the take-home message, how to enhance stability with augmentation if you need more. The first one is plate on nail, especially to acquire the early weight bearing. It is very useful to this kind of plate on nail construct. And second one, in the elderly fixation, you do the plating. The dual plating is very nice. In distal femur and periphrostic tibia fracture, or after the periphrostic femur fracture following the total vascular fracture. Yeah. Thank you so much.